Encopresis, medically defined as the repeated defecation in inappropriate places, represents one of the most challenging and emotionally distressing conditions affecting children and their families. This complex disorder goes far beyond simple toilet training difficulties, encompassing a spectrum of physiological, psychological, and behavioral factors that intertwine to create a persistent pattern of soiling that can devastate a child's self-esteem and family dynamics. The condition typically manifests in children who have already achieved bowel control, making the regression particularly troubling for parents who struggle to understand why their previously toilet-trained child is now experiencing repeated episodes of inappropriate defecation. The clinical definition of encopresis requires that the inappropriate defecation occurs at least once monthly for a minimum of 3 months in children aged 4 years or older, distinguishing it from normal developmental variations in toilet training. This diagnostic criterion acknowledges that occasional accidents are part of typical childhood development, but encopresis represents a persistent pattern that significantly impacts daily functioning. The inappropriate places where defecation occurs can vary widely, including underwear, clothing, floors, hidden corners of homes, school bathrooms, or virtually any location that is not the designated toilet. Understanding the multifaceted nature of this condition requires examining both its primary manifestations and the underlying mechanisms that perpetuate the cycle of inappropriate defecation. Medical professionals categorize encopresis into 2 distinct types based on the presence or absence of constipation and overflow incontinence. Retentive encopresis, which accounts for approximately 90% of cases, involves chronic constipation that leads to overflow incontinence, where liquid stool leaks around impacted fecal matter in the colon. Children with retentive encopresis often develop a fear of bowel movements due to previous painful experiences, leading them to hold stool, which paradoxically worsens the constipation and creates a vicious cycle of retention and overflow. Non-retentive encopresis, though less common, involves the voluntary or involuntary passage of normal consistency stool in inappropriate places without underlying constipation, often associated with behavioral or emotional factors rather than physiological dysfunction. The physiological mechanisms underlying encopresis are complex and often misunderstood by families and even some healthcare providers. When children consistently retain stool due to fear, pain, or other factors, the rectum becomes stretched and loses its normal sensitivity to the presence of fecal matter. This rectal distension impairs the normal urge to defecate, leading to a condition where children may not even realize they need to have a bowel movement until inappropriate defecation has already occurred. The stretched rectal walls also lose their muscle tone, further compromising the child's ability to control bowel movements effectively. Additionally, chronic constipation can lead to the formation of hard, impacted stool that requires significant straining to pass, creating painful experiences that reinforce the child's reluctance to use the toilet appropriately. Psychological factors play a crucial role in both the development and maintenance of encopresis, creating a complex interplay between emotional distress and physical symptoms. Children experiencing encopresis often develop intense shame, embarrassment, and anxiety about their condition, which can exacerbate the problem by increasing their tendency to avoid bowel movements or hide their soiling behaviors. The repeated defecation in inappropriate places can lead to social isolation, academic difficulties, and strained family relationships, creating additional stress that perpetuates the cycle. Many children with encopresis also experience secondary behavioral problems, including oppositional behavior, withdrawal, and decreased self-confidence, as they struggle to cope with the social and emotional consequences of their condition. Family dynamics and parental responses significantly influence the course and resolution of encopresis, making family education and support essential components of effective treatment. Parents often experience frustration, embarrassment, and anger when confronted with repeated episodes of inappropriate defecation, particularly when they believe their child is engaging in these behaviors intentionally. This misunderstanding can lead to punishment, criticism, or shame-based interventions that actually worsen the condition by increasing the child's anxiety and resistance to treatment. Conversely, Families who receive proper education about the involuntary nature of most encopresis cases and implement supportive, non-punitive approaches tend to see better outcomes and faster resolution of symptoms. The diagnostic process for encopresis requires a comprehensive evaluation that includes detailed medical history, physical examination, and sometimes additional testing to rule out underlying medical conditions. Healthcare providers must carefully assess the child's bowel habits, dietary patterns, toilet training history, and any associated symptoms such as urinary incontinence or behavioral problems. Physical examination may reveal evidence of chronic constipation, such as palpable stool masses in the abdomen or rectum, anal fissures, or other signs of prolonged retention. In some cases, imaging studies or other specialized tests may be necessary to evaluate the extent of constipation or rule out anatomical abnormalities that could contribute to inappropriate defecation. Treatment of encopresis typically involves a multifaceted approach that addresses both the physiological and psychological aspects of the condition, recognizing that successful intervention requires more than simply treating constipation. The initial phase of treatment often focuses on disimpaction, using oral or sometimes rectal medications to clear accumulated stool from the colon and rectum. This medical intervention must be carefully managed by healthcare providers, as aggressive disimpaction can be traumatic for children and potentially worsen their fear of bowel movements. Following disimpaction, maintenance therapy with stool softeners, fiber supplements, or other medications helps prevent reaccumulation of stool while the rectum regains its normal size and sensitivity. Behavioral interventions form a crucial component of comprehensive encopresis treatment, helping children develop healthy toilet habits and overcome the anxiety or resistance that may contribute to inappropriate defecation. Structured toilet sitting schedules, often implemented after meals when natural gastrocolic reflexes promote bowel movements, help children establish regular bowel habits and increase their awareness of normal bodily sensations. Positive reinforcement systems, such as reward charts or small incentives for appropriate toilet use, can motivate children to participate actively in their treatment while building confidence and reducing anxiety about bowel movements. Dietary modifications often support medical and behavioral interventions by promoting healthy bowel function and preventing the recurrence of constipation that can trigger inappropriate defecation. Increasing fiber intake through fruits, vegetables, and whole grains helps maintain soft, easily passed stools, while adequate fluid intake prevents dehydration that can contribute to constipation. Some children may benefit from reducing constipating foods, such as excessive dairy products, processed foods, or foods with minimal fiber content. However, dietary changes should be implemented gradually and with consideration of the child's nutritional needs and food preferences to ensure compliance and prevent additional mealtime stress. The prognosis for encopresis is generally favorable when appropriate treatment is implemented consistently and families receive adequate support and education about the condition. Most children with encopresis respond well to comprehensive treatment approaches, though resolution may take several months to achieve as the rectum gradually returns to normal size and function. Factors that influence treatment success include the duration of symptoms before intervention, the presence of underlying behavioral or emotional problems, family compliance with treatment recommendations, and the child's motivation to participate in treatment. Early intervention typically leads to faster resolution and prevents the development of secondary complications such as severe behavioral problems or family dysfunction. Long-term outcomes for children with successfully treated encopresis are excellent, with most children achieving normal bowel control and experiencing no lasting effects from their condition. However, some children may remain at higher risk for constipation throughout their lives and may need ongoing attention to diet, exercise, and bowel habits to prevent recurrence. The psychological impact of encopresis can also have lasting effects if not properly addressed, making it important for families to continue supporting their child's emotional recovery even after the physical symptoms resolve. Children who receive comprehensive treatment and family support typically develop healthy coping skills and resilience that serve them well in other areas of life. Prevention of encopresis focuses primarily on early recognition and treatment of constipation, as well as promoting healthy bowel habits from an early age. Parents can help prevent encopresis by ensuring their children maintain adequate fiber and fluid intake, get regular physical activity, and develop consistent toilet routines. Avoiding overly aggressive or punitive toilet training approaches can also prevent the development of fear or anxiety around bowel movements that may contribute to retention and subsequent inappropriate defecation. When constipation does occur, prompt medical attention and appropriate treatment can prevent the progression to encopresis and its associated complications. Healthcare providers play a crucial role in educating families about encopresis and providing ongoing support throughout the treatment process. This education should emphasize the involuntary nature of most inappropriate defecation and encopresis, helping families understand that children are not engaging in these behaviors intentionally or to seek attention. Providers must also address common misconceptions about encopresis and help families develop realistic expectations about treatment timelines and outcomes. Regular follow-up appointments allow for monitoring of progress, adjustment of treatment plans, and continued family support as children work toward recovery from this challenging condition.